So it's my great pleasure to welcome you to this year's Sports Cardiorespiratory Medicine Conference hosted by the Institute of Sport, Exercise and Health in London. As many of you will know, this is our third running of this conference, and this year we've decided to spread the conference over two sequential nights. It's my pleasure to introduce the sports pulmonology or respiratory component, and we're going to kick off this evening focused on a theme about what the air that athletes breathe. And I thought this would be of interest to people because often I'm asked the question, what can we do to try and improve the environment or the air that athletes breathe, and how does that really affect their ability to compete and perform? And so, as I'll talk about in a minute, we've assembled a really great lineup of speakers who are going to take you through some of the important issues in terms of environmental challenges, and hopefully this will help you looking after athletes and optimizing their health and also their performance. As means of background, some of you will know me already, but otherwise I work as a respiratory physician at the Royal Brompton Hospital in London, but I'm also the lead for the Sports Respiratory Service at the ISEH, and I advise the UK Sports Institute and Team GB as a respiratory physician. I've also been involved over the past few years working with colleagues for the International Olympic Committee and also for the British Thoracic Society, creating some guidelines to help us improve the care or the respiratory care for athletic individuals. And I'll touch on that in this introductory talk. And so by virtue of you joining this evening, you're already aware of the challenges that athletes face when it comes to their breathing. They often have to train or compete in what might be termed inhospitable conditions or exposed to noxious environmental situations. Certain chemicals they'll have to breathe in, exposures such as smoke, thermal challenges, and the challenges of different seasons, including allergens that they're exposed to. And that's all before we even think about the type of problems that athletes get when they're exposed to viruses. It may not be, therefore, very surprising to know that when we ask athletes or athletic populations about the impact of training and sport on respiratory health, there's a high burden of issues. Surveys have shown that athletes often report problems with their breathing, with wheeze, with cough, with phlegm, as you can see here on the data presented from a study in Canada several years ago. We also know that that can lead to clinical conditions. And of course, asthma is the most common chronic medical condition in athletes. And a recent analysis for the IOC that we were involved in showed that probably 1 in 4 endurance elite athletes have problems with what might be best termed lower airway dysfunction, or a type of clinical condition that looks a bit like asthma or exercise-induced bronchoconstriction. Even for people who are recreational runners or recreational athletes who take part in sports such as running the marathon, you can see from this data, again, a number of years ago now, how common it is to have troublesome respiratory tract symptoms in the days following an event, suggesting that the respiratory system is really challenged by performing endurance activity and endurance sport. If we look at the elite level, of course, the type of illnesses or ailments or problems that athletes run into at elite competitions such as the Olympic Games or in international sporting events and world championships, respiratory issues are right at the top of the list of problems that can scupper an athlete's ability to compete and to perform at the top of their ability. You can see the very high prevalence figures that are reported, and there's numerous papers published, particularly in the BJSM, illustrating the important impact of respiratory ailment in the context of elite sporting performance. Now, you will be aware that a key mandate or target of the Olympic movement is to be able to protect the health and well-being of individuals who are partaking in sport. And so it was a great pleasure to be invited to join other expert colleagues from around the globe and chaired by Martin Schwellnus in South Africa to join them in an expert panel trying to see if we can create some documents that address and try to optimize respiratory management in athletic individuals. And we were creating these documents for several years, but they were published in the British Journal of Sports Medicine as open access documents last year. They'll come out in print this year. But the documents provide two key statements. a part 1 which covers acute respiratory infections, and a part 2 which covers the non-infective causes of acute respiratory illness. And they're pretty hefty documents with lots of research, figures, tables that provide you with insight. But they touch on some of the environmental challenges that athletes face, and particularly ways in which clinicians should perhaps approach acute infective type symptoms and the way to best manage them in athletes of all levels. Within the document, there are flowcharts. I know these look rather small on the page now, but if you turn to the open access documents, you can see that there are flowcharts which help clinicians who are addressing respiratory problems in athletes. And I hope that audience and readers will find this a useful and important source of information. I've also been involved with creating a similar such document for the British Thoracic Society, and again, this resource is free to access through the britishthoracic.org.uk website, and again has some simple images and figures to try and help clinicians facing athletes with respiratory symptoms to try and work out how best to access the right type of test, and then to use the evidence base to provide the appropriate and logical treatment. Now, at the ISEH, I run a dedicated sports respiratory clinic with colleagues in respiratory physiotherapy, and particularly Julie Moore. And this is the type of breakdown of the type of referrals that we get within that service, where you can see that the majority of people being referred have asthma type issues. They have wheeze, cough, phlegm, those types of issues. And one of the things that I'm often asked by athletes is, quite rightly, why has this suddenly arisen? Why do I now have problems where, for instance, maybe a couple of years ago I didn't have issues? Or why do I have certain issues when I'm in certain parts of the world trying to compete? Is it something to do with the environment I'm surrounded by? Is it something to do with the noxious type chemicals or pollution that I'm exposed to? And so rather selfishly, I've created this webinar to try and learn as much as I can so that I can best inform athletes who are asking me these questions. And of course, when they come to see me, they've travelled into central London where the clinic is based. And I'm hoping that particularly Professor Koehle will tell us about the interaction between noxious car-based and environmental pollutants and how that might affect my athletes' breathing. So as I said at the very start, tonight I'm delighted to welcome 3 fantastic speakers who are going to give us a broad overview of various and very interesting areas of environmental challenges and the challenges that are placed for athletes of all abilities, really, but of course, particularly with an eye on the competitive or elite athlete. Michael Koehle is coming from Vancouver. He's an Ironman himself and has done an incredible amount of important research, including publishing the Canadian guidelines recently in the British Journal of Sports Medicine, providing insight on how we can address the ability for people to safely perform sport in the context of a polluted environment. We have Professor David Hughes from Australia. And again, many of you will have read his very insightful documents and work that's come out from the AIS, particularly talking about managing athletes' exposure to fire and bushfire smoke. And of course, that was a challenge, certainly within elite tennis competitions in his part of the world over the past few years. So I look forward to hearing what he has to say and guidance in that respect. And then finally, Dr. Guy Scadding, who's a colleague of mine at the Royal Brompton Hospital, and who's a world expert in the management of allergy. And allergy is a key issue in athletes. Certainly within the UK Sport Institute, we find that at least a third of the athletes have active seasonal rhinitis that we're working hard to try and manage and optimize. Before I hand over to those fantastic speakers, a quick plug. We have a specialist Breathing to Win face-to-face workshop day run by my colleague and respiratory physio lead, Julie Moore, that is going to look at trying to help people understand how best to help athletes breathe in the most efficient way, and to particularly address issues such as dysfunctional breathing or exercise-induced laryngeal obstruction. And that really is a hands-on workshop where we'll be doing live demonstrations of those types of interventions to try and help. So I'd like to thank you for listening to me in this introduction. These are my contact details and also the plug for the book on the complete guide to respiratory care in athletes. But without further ado, I'd like to introduce our first speaker now, and I look forward to joining you for the Q&A within this session.
Hello, and thank you for attending this session. And I'd like to thank the organizers, Professor Hull and Dr. Gati, for putting together a great program today. So we'll be talking about air pollution and exercise. And first of all, I'd just like to do a little bit of a background on in terms of both air pollution and exercise. And so it's not controversial that air pollution is very harmful to health. It causes an increase in mortality and many diseases across many systems. Some of the main ones would include cardiovascular disease, such as acute coronary syndromes, respiratory disease, such as COPD and lung cancer. It increases the incidence of type 2 diabetes, and it also increases the incidence of dementia. So it's definitely harmful for our health. But conversely, uh, exercise, physical activity, and sport is really beneficial for health. We use it to both prevent and to treat many diseases. And the area of concern or the question is what happens when we combine air pollution and exercise? Because with exercise, there's an increase in metabolic rate, and so there's an increase in breathing and specifically minute ventilation. So that has a potential to increase the dose of air pollution that's ingested. Also, during moderate and intense exercise, there's a predominance of oral breathing or mouth breathing over nasal breathing. And so by breathing through the mouth, we're bypassing the filtration and humidification effects of the nose. And that might lead to an increase in deposition of pollutants in the lungs. Also, our tidal volume is greater, which can lead to more deposition. And the pulmonary vascular blood flow is increased as well. So pulmonary diffusing capacity is greater, and there may be more potential for translocation of pollutants into the systemic circulation. So for all those reasons, it makes sense that exercise when the air quality is poor or in areas in times of high air pollution could have synergistic harmful effects. And so when we try to understand the interaction between exercise and air pollution, we need to think about really four situations. And so I kind of put together this matrix. We need to think about the acute effects of exercise and air pollution and the chronic effects. And those effects need to be broken down into both health effects, and then for the purpose of this webinar today, the performance effects as well are important. And we study them differently with different research paradigms with advantages and disadvantages. So in terms of the acute effects, we do a lot of exposure studies in both the laboratory and in real world exposures. And for acute performance effects, there is some emerging data from really observational studies, especially in team sports where the athletes, especially football or soccer, the athletes are quite instrumented. And so we can get some data from that. In terms of chronic effects, we really rely on epidemiological studies to look at the health. And in terms of the chronic performance effects, that's a bit of a black box that hasn't really been investigated yet. And so I thought I'd just highlight some of the key epidemiological studies to understand sort of the long-term relationship between air pollution and exercise. And these studies look at important clinical outcomes like mortality or hospital admissions, acute coronary syndrome, incidence of diabetes or dementia. And what they show is that by and large, air pollution is bad for all of these outcomes, and physical activity is beneficial, but that the air pollution doesn't really prevent the beneficial effects of physical activity. There's one potential caveat there that in this Reichland study at the bottom right here, at the very highest levels of air pollution, the positive effects of physical activity didn't reach statistical significance. And there's still a trend there, but it wasn't statistically significant. So we take that to mean that air pollution is bad for our health. We need to reduce our exposure as much as possible, and exercise is good for our health. And so over the long term, staying active, even as air quality gets worse, is important from a health point of view. So now when we talk about the acute or the short-term, both health and performance effects, we need to really think about what I call the air pollution recipe. And air pollution, if you want to make air pollution, you basically make a mixture of gases, such as ozone or oxides of nitrogen, and particles like pollen and dust and heavy metals and liquids. And that recipe varies over the time of day, over season, and varies by location. And so if you're looking at the health effects of air pollution or performance effects, you want to consider the individual recipe. I like the analogy of dessert here. If someone said, what are the health effects of dessert? You could imagine that the dessert on the left has more harmful health effects than this dessert on the right. And so a couple of situations worth discussing. I work with Athletics Canada, which is our national track and field team. And they were competing at the World Championships in Doha a couple of years ago, and it was very high in particulate matter air pollution from industrial sources and construction and combustion. And then 2 years later in 2021, when we went to the Tokyo Olympics, ozone air pollution was more of a factor because ozone is created by ultraviolet light from the sun converting primary pollutants like volatile organic compounds into ozone. So it's really bad on those hot, sunny days. And so it's typically quite high in Japan. It's actually the highest levels of ozone in the OECD. So when we talk about these acute effects, keep those situations in the back of your mind, because we're going to have different recommendations based on the different air pollution recipes. And so recently we published this review where we looked at all the published research that looked at acute exposures to air pollution with moderate to vigorous physical activity. And we divided it into three main recipes. One was traffic-related air pollution here on the left. The other was diesel exhaust. That's a common model for exposure studies. And then we looked at ground level ozone, which I'll talk about in a second. And we use these harvest plots because we can't use a meta-analysis for these data because the studies are just too heterogeneous. And what it shows is each bar represents a published study. The height of the bar represents the risk of bias, and the tone of the bar represents the sample size. And if we look here at the diesel exhaust on the right or the traffic-related air pollution on the left, there's a bit of a conflicting picture in that some studies show beneficial effects in terms of pulmonary function or systemic inflammation with exercise in high levels of these air pollutants. And then other studies on the left show harmful effects. So it's quite equivocal, and it looks particularly equivocal when we compare it to ozone. So here, it's the same kind of harvest plot, but you can see on the left here, there's a preponderance or an overabundance of studies that show that there's harmful effects in terms of pulmonary function, symptoms, inflammation, and exercise response when people are exercising acutely in high levels of ozone. So it's really quite clear. And so what athletes will find is they'll find more chest tightness. If we measure lung function, we'll see decreases in FEV1. And we also see performance decrements with ozone that are more consistent than with the other pollutants. We recently published this consensus statement looking at best evidence in terms of reducing air pollution's harmful effects during exercise. And we did it with a bunch of experts from Brazil, Spain, France, and Canada. And so I've been asked to summarize those findings today to give you sort of practical guidelines. So the most important thing that we can do is that we can monitor air pollution levels. And the tools that you're going to use will vary based on your home location, but in general, government websites are a great source of air quality data. I also like to use this app. It's called Plume, Plume, and I like it because it does a future forecast of what the air quality is going to be like based on historical data as well as based on weather patterns. And that's helpful when planning the next day training, knowing when the air quality is going to be the best and the worst. These monitoring and forecasting solutions rely on a mix of satellite data, local fixed sites. Those are generally maintained by the local government. And then if you actually have a fixed site at your training venue, that's probably the very best source of data. An emerging tool is these wearable air pollution monitors. We haven't found one that we're happy with in terms of reliability, but it's a changing field. And this website, the AQMD website, they test all the sensors on on the market, and they publish the data. And it's really helpful to see how good and how bad some of the wearables are. So a key strategy is reducing air pollution exposure by distance, meaning moving your training and, if possible, competition as far away as possible from sources of air pollution, such as traffic arteries or construction sites or industrial sites. And this is really important in that pollution levels drop off very quickly within just a few meters from a source. And so moving from the outside of a park to the center of a park can make a big difference. I like to look at this map from Portland, Oregon, that shows 3 different pollutants here in the 3 figures and the levels. And you can see these arteries around the outside, these major roads, have very high levels of air pollution. But once you get away from the arteries, the levels drop off significantly. So when planning, training, and competition, if you have the flexibility to move even a small distance away from these sources, you're going to make a meaningful impact on air pollution exposure. The other key strategy is reducing your exposure by time. And so the air pollution recipe is always changing by time of day, location, but also by season. And you can try to take that into account when planning, especially planning training, to minimize air pollution exposure. We're going to be learning a lot more about seasonal exposures in the next session, which is focusing on bushfires and wildfires. But if we look at the within day changes in air pollution, you can see the figure on the left is ground level ozone. And ground level ozone, remember, is created when ultraviolet light converts primary pollutants into ozone. And so you can see it's really high late in the afternoon during when the sun is at its maximum effect, and then it drops down overnight and is really low early in the morning. On the right, we have a similar figure, but for particulate matter, and you can see that the pattern's a little bit different. There's a dip in the morning, but then there is a dip sort of in the late afternoon, right when ozone is quite high. So you can imagine that you need to plan your within day training based on which pollutants are worse. In a high particle environment, then late in the afternoon is not a bad time, but a high ozone environment like Paris 2024, then that will be a high ozone time or a high pollution time. Okay, so the other thing that was, I guess, factor that was a bit surprising is exercise intensity, in that when we got into this area, we expected a really synergistic effect between exercise intensity and effects of air pollution. And granted, we need more studies, but the studies that have been done have shown sort of no worsening. And if anything, let's just leave it at no worsening effect with higher intensity exercise. And so the recommendation that we take from that is that it's the total inhaled dose of air pollution, which is the concern. And so the kind of workout that we want to be really cautious or avoid is those very long, low intensity workouts. You're not getting a benefit from lowering the intensity, but the excess duration is increasing the inhaled dose. And so in a period of time where the air quality is particularly poor, it is reasonable to consider shorter, more intense interval type or tempo type workouts where the total inhaled dose is not as much as these longer, low intensity ones. So if you have the flexibility in the training program to do those kind of things, that will make a meaningful difference in reducing the air pollution exposure. A really important factor is that air pollution is bad for us 24 hours a day. And so when you're working with exercisers and athletes, you want them to really consider air pollution exposure at all times. And we did this study a few years ago where we looked at exercise pre-exposure, air pollution exposure prior to exercise. We had participants exposed to diesel exhaust at rest for 60 minutes before a time trial. And we found that even with the pre-exposure to air pollution, there was an increase in heart rate during exercise and a decrease in the exercise-induced bronchodilation that we expect during exercise. And so the recommendation is to really consider air pollution exposure 24 hours per day. and to reduce that exposure. In a high particle environment, masks that filter out particles, like an N95 mask, that could make sense on the way to and from competition, just to reduce that overall exposure. It's not as effective in ozone because ozone is a gas and penetrates a mask like that. But other strategies like spending time in an indoor environment where you're assured that the air quality is good or that you have air filtration, that's an important strategy as well. There has been some concern that bronchodilators might increase the inhaled dose of a pollutant and increase the adverse effects. And that comes from animal data and also from just the rationale that by bronchodilating the lung, you may increase the deposition of particulate matter, especially in the lung. And so we've done a bunch of studies in both ozone and diesel exhaust in people with asthma and exercise-induced bronchoconstriction, and there's no worsening of effect when they take the medication in the pollution condition versus the filtered air condition. And so we take that to mean that athletes should maintain their medication as prescribed by their physician and not reduce it in an effort to reduce the pollution dose, and not increase it as well in response to air pollution. So just to maintain them at the prescribed level. From a nutritional point of view, there is some evidence that antioxidant supplements, namely vitamin E and vitamin C, seem to have an effect, especially in terms of performance, but also in lung function, and especially in ozone exposure. And so that's an easy thing to operationalize, especially if you have access to a sport dietitian as well. And so that's one good strategy, vitamin E and vitamin C. Training indoors is often recommended. And if you can be assured that your air quality indoors is better than outdoors, and you have the flexibility to train indoors, then that makes good sense. People just need to be aware that there are indoor sources like climbing chalk, ice resurfacing machines, candles, wax. As well, there can be a lot of penetration of outdoor air pollution indoors as well. And so you need to be confident that the air quality is better indoors, and then it's often a good solution. So getting back to the two recipe scenarios, I wanted to give some practical suggestions for athletes based on the high particle scenario and the high ozone scenario. And so what I did is I put the standard recommendation in black here, and then the specific recommendation in blue. So for competitions in high traffic-related air pollution, diesel exhaust situation, you want to always avoid air pollution 24 hours a day on the way to and from competition. And in that situation, masks that filter out particles may be beneficial, especially on the way to and from competition. We want to treat the asthmatics as prescribed, always. And then in terms of diesel exhaust and traffic-related air pollution, we actually reassure the athletes that there's no clear acute performance decrements in those situations. And that comes from a number of studies, both from the Brazilian researchers and from our research group, is we really can't show any acute performance effects. So we really try to reassure the athletes that, they may feel a little different, but their performance should be maintained. But that's different in ozone. And so again, in a high ozone environment, we want everybody to avoid pollution exposure, reduce it as much as possible, stabilize their asthma. But in terms of symptoms, in a high ozone environment, we actually tell athletes they may expect to have more tightness, shortness of breath, even a little bit of coughing. And if they can actually train prior to competition in that environment, there may be a little bit of a benefit for that. And also in the high ozone environment, vitamin C and vitamin E for at least 2 weeks prior to competition may have a beneficial effect. There's also a bit of a placebo effect too when the athletes feel like they're doing something to manage the air pollution risk as part of that. So in terms of take-home message, air pollution is bad for your health. It can be bad for your performance, especially ozone, and exercise has good positive effects on health that are by and large not prevented by air pollution. And when you're working with athletes around training and competition, really consider the air pollution recipe and tailor your strategies to that. I'd like to thank some of the key contributors to the presentation, and please don't hesitate to reach out to me if you have any questions or need advice on that. And I think we'll be moving to a question period next. Thank you.
Well, thank you, Mike, for an absolutely fantastic talk and a great overview of some really key and important points for people performing sport in and around the context of polluted environments. For those of you still online, please send your questions through now so I can forward them to Mike and we can ask him in this 5-minute Q&A session. And keep the questions coming throughout the talks, please, and then I will filter them to the speakers at the end. While you're thinking, perhaps I could get started, Mike, by asking you a question about the potential adaptations that occur when an athlete moves into a polluted environment, for instance, in and around a big competition. Is there a period at which people should travel into that area? Is there time that athletes need to adapt and become familiar and their pulmonary systems to adapt to the local environment? What are your thoughts on or recommendations on that?
Yeah, thanks, James. There is some evidence for ground level ozone that we can adapt to it from two different types of studies. There was a lot of research done in the 80s where they would directly expose people to ozone, and they would find that especially the pulmonary function effects after about 2 or 3 consecutive days, they would diminish. But there's also more recent performance data that shows that people that come from a high ozone environment will compete. Their decrement in performance would be less in a high ozone environment. So we take that to mean that there's 2 lines of evidence that there may be a bit of a subacute adaptation to ground level ozone. That is not present with more particulate-based air pollution. There's only one study that looked at it, and they only looked at 2 consecutive days exposure. And so we don't really know much about that. So in terms of the ozone, there may be a benefit. The thing about high ozone environments is they're also high heat environments because you're requiring the sun in most cases to create the ground level ozone. So for elite competition, if you're already doing a heat pre-acclimation, our sort of general guidance is also monitor the ozone, and they may be actually getting combined heat adaptation as well as ozone adaptation at the same time. But that's something we need to really research a little bit more and look at the sort of health effects of that as well.
Okay, great. So questions coming through. There's questions about the masks that people should wear or think about, and particular questions come through about other concerns about mask material even being harmful. So perhaps your thoughts on masks and how athletes can get the most out of wearing a mask in these environments.
Yeah, and so masks, especially a properly fitted N95 type mask, can be very effective at reducing particles coming in. It won't be effective against the gases like ozone and nitrogen dioxide. And so in a high particle environment, wearing a well-fitting mask can be beneficial, especially in the lead up to competition and training, and then post-competition and training. Remember, air pollution is bad for our health 24 hours a day. And so those other 23 hours, we want to reduce the air pollution exposure. And that can be in a climate controlled filtered environment or on the way to and from training wearing a mask. And so that is one strategy. Generally during competition, people won't want to wear or tolerate a properly fitting N95 mask. I don't think there's much benefit for other types of masks in that aren't properly fitted and aren't really reducing the particles. But from a high quality mask that's designed like that, I don't think there's any specific concerns about the mask particles itself coming in, not that I'm aware of. I hope that answered that question.
And just as an aside, I was asked a couple of months ago about whether these masks are waterproof or whether sailing athletes could wear them. especially if they're exposed to dust environments or more or close to cities, etc. I mean, are they waterproof, any of these masks, or what would you say about that?
You know what? I'm not sure, but you know what I would recommend is for COVID, we were wearing masks that didn't have an exhalation valve. But there's very similar masks made by the same manufacturers that are for workers that are working in a high particle environment where it has a low resistance mask valve that opens when you exhale. And for athletes or sport, having that valve opening, you're going to lose a lot of the humidity will be released from the mask, and you won't build up that humidity and moisture in the mask. And so it'll probably be a little bit more comfortable if people are wearing it during activity. But I don't know directly about the water resistance for them. I'd assume that they would be have some basic water resistance.
Okay, well, listen, thank you very much again. I know this is a very short Q&A session. Please feel free, delegates, to pop your questions in, and I'll try and filter them through to Mike if he's going to stay for a little bit, and respond online if I can to your specific questions. And so it's my great pleasure now to move on and introduce Dr. David Hughes, who comes to us from Australia. I don't know what time it is out there, but he has done some very nice work on behalf of the Australian Institute of Sport, and he's going to talk about the challenges of athletes being exposed to bushfire smoke environment, which is an increasing problem. So many thanks, David, and we'll get started. Thank you.
Good evening from Canberra. Thank you very much for the opportunity to participate in this webinar. I've had the pleasure of living in London twice. They've both been really positive experiences both times. And so I consider London my second home. I would much rather I was there in person for this evening, but that can't be. So I'm nevertheless very happy to be here and presenting remotely. As many of you will be aware and recall, during the final quarter of 2019 and the first quarter of 2020, we had extensive bushfire activities across forested regions of Australia, particularly down the eastern seaboard. The scale and duration of these bushfires was unprecedented even for Australia, where we are used to such events. Today, I'm obviously going to be presenting about the effect of bushfire smoke in athletic settings, but I just thought we should not lose sight of the fact that, nor diminish the really terrible acute effects that bushfires have on a community in terms of loss of lives, loss of livelihoods, loss of property, loss of fauna and flora, and of course the huge emotional toll that these events have on a society. But we are in the business of sport, and that's what we're talking about this evening. So without trivialising those other matters, I am going to proceed and discuss the effect that bushfire smoke has on athletes. In my role here at the AIS, during those bushfires, I was inundated with requests for advice by our high performance sport sector partners and from organisations in community sport. In this presentation, I'm going to discuss the features and constituents of bushfire smoke, the effect that bushfire smoke has on athletes, and recommended strategies for managing your athletic cohorts in environments affected by bushfire smoke. So bushfire smoke is created by the combustion of biomass. The constituents differ from that of car fumes and industrial pollutants. Bushfire smoke is mostly carbon dioxide, water vapour, carbon monoxide, particulate matter, hydrocarbons and nitrogen oxides, trace minerals and some volatile organic compounds. You will find some traces of heavy metals attached to particulate matter, but generally speaking, compared to industrial pollution, heavy metals are not found in huge quantities in bushfire smoke. Particulate matter refers to the small particles characterised according to their diameter. PM10s refers to particulate matter which are less than 10 micrometers in diameter. PM2.5s, being a subset of PM10s, are obviously 2.5 micrometers in diameter. In bushfire smoke, there's a relatively constant ratio of PM 2.5s to PM 10s, whereby PM 2.5s account for about all over 98% of the overall PM 10s. PM 2.5s are more relevant also because being smaller, they can travel deeper into the lungs and have a more significant effect on respiratory health. So the summary of all that is that PM 2.5s can be considered a reasonable proxy for exposure to pollutants in bushfire smoke. This graph gives us an idea of the PM 2.5 levels that we saw in Australia during this bushfire period. The red line you can see on your screen is the historical level of PM 2.5s that we see in Australia, which is down around 7 micrograms per cubic metre. The green line is sort of the line that we consider, if you like, a health normal line. So below that level, we don't get too concerned about health effects, and above that line, we do start to have concerns. And the blue line there is the actual PM 2.5 level that we saw at the end of 2019 and the start of 2020. And you can see that we were well into the realm of having bushfire smoke levels and particulate matter levels that we have concerns about effects on the health of individuals. So what are the effects of these chemicals on exercising individuals? Well, carbon monoxide, as I'm sure you're aware, has a great affinity for hemoglobin, and in binding with hemoglobin displaces oxygen. And even though the carbon monoxide levels associated with bushfires may not exceed what we would consider occupational safety standards, if you've got high-level athletes competing at a very high level, and there is any exposure to carbon monoxide, this can displace oxygen and would be expected to have an acute net performance impairment in people exercising at a high level. Bushfire smoke also contains, as we discussed, nitrogen dioxide, and when nitrogen dioxide reacts with water, it can form nitric acid, which is a respiratory irritant. And this can aggravate pre-existing respiratory diseases, particularly asthma. And you'll hear me say a few times during this presentation that we also see significant respiratory effects in individuals who had no pre-existing asthma and who, even at the time of their discomfort, are not presenting with bronchospasm. So exposure to nitric acid can produce respiratory symptoms such as coughing, wheezing, and difficulty breathing, and it can make people have increased susceptibility to respiratory infections. Bushfire smoke can produce local toxic effects through the respiratory tract, which at a sort of more granular level reduce surfactant production in alveoli and therefore impair oxygen transfer across the blood-gas barrier, impair mucociliary clearance, result in preferential damage to secreting and ciliated cells, and through all of those mechanisms cause bronchospasm, breathlessness, and dyspnea. And the collective effect of these impacts on the respiratory tree impair microbiological defences, making people more prone to conditions such as bronchitis and pneumonia. At a population level, during those 19 weeks of continuous fire activity, as you would expect, we saw epidemiological evidence of people suffering the negative effects of exposure to bushfire smoke. So we had 417 excess deaths, over 1,100 excess hospitalisations for cardiovascular problems, over 2,000 excess hospitalisations for respiratory problems, and over 1,300 presentations to emergency departments with asthma. And it's important to remember that these statistics did not include primary healthcare attendances or ambulance calls. Most of our athletes are not going to get anywhere near a fire, hopefully, but when fires like these do affect a community, you will have people who are trapped in situations close to the source of the fire, and you will have people who are engaged in fighting the fire, and these individuals can suffer quite significant injuries such as supraglottic thermal injuries, chemical injuries to the upper and lower respiratory tract, and asphyxiation and systemic toxicity from lung-mediated absorption of high levels of smoke constituents. But let's talk about athletes. There's a huge variability between individuals in relation to their airways responsiveness. And again, bushfire smoke can have a negative effect on those who don't have asthma and who have never had a history of respiratory illness. But certainly asthmatics are much more sensitive to the effects of bushfire smoke in general than those who are non-asthmatic. It's very difficult when you're dealing with an individual to estimate the threshold dose of smoke inhalation that particular individual can be expected to tolerate, or at which level they can be expected to have health effects. Here at the AIS, we have a big rowing contingent based around the AIS, and we saw many presentations of our rowing athletes, and again, many of whom had never had any history of respiratory illness in the past. And when we tested those individuals while they're having their symptoms, their spirometry was normal, in that they had no decrease in their FEV1, but they nevertheless experienced discomfort. They would describe a burning sensation in their lungs, and they would, coughing fits, etc., without having measurable bronchospasm. Exercise exercise increases the exposure of athletes to the negative effects of bushfire smoke. Obviously, when people are exercising, particularly in high intensity aerobic-based activities such as rowing, long-distance cycling, long-distance running, long-distance swimming, the tidal volume is increased. The increased tidal volumes reduce the amount of air that is filtered through the nasal cavity as breathing switches from predominantly nasal-based to oral, consequently meaning that more particulate matter may be deposited in the lower airways. The increasing minute ventilation increases the particle deposition fraction in the lungs. So as a sort of measure of those factors, someone exercising at a high level in an aerobic-based sport can be expected to have 10 times the deposition of particulate matter in their airways than someone who is at rest someone at rest. So how do we manage people and their athletes and their health risks in an environment where they are required to continue exercising? I think firstly, the first thing you want to do is make sure that you know your athletes, and if you're going into a situation where there is going to be high levels of bushfire smoke, make sure you're aware of which athletes within your group have a past history of bronchial hyperresponsiveness. Remembering that even those who have no past history of respiratory disease may be affected by bushfire smoke, I think it's important that you educate all athletes and coaches about the inherent risks of bushfire smoke. And I think it's important to monitor the prevailing environment and of PM2.5 levels in the air. Now, here at the AIS, we have government monitoring stations around us. We have 3 that are within 5 to 10 kilometres. But what we found during this bushfire period was that the readings at these monitoring stations, even though they're put up on a website on an hourly basis, did not necessarily reflect what was happening on the ground here at the Institute. And I think it's just really important to emphasise that PM2.5 levels vary very quickly across time. So all it takes is a change of breeze, wind direction and wind strength to either significantly decrease or significantly increase your PM2.5 levels in a particular location. And the PM2.5 levels also vary quite significantly across relatively short distances, geographical distances. So we had people with these monitors, and I know that I think some of your presenters tonight are not particularly enamoured of these handheld measuring devices for PM2.5s. Our experience here at the AIS and in sporting bodies around Australia was actually quite positive with these. Certainly I can speak from personal experience here at the AIS that we found that these devices reflected the PM 2.5 levels that they were reading reflected what we were seeing and smelling here at in the environment on our fields here around the AIS. If we still have these devices in stock, and if I go out now, they'll be reading around 7, so well within the safe range. When we had the bushfires on here, we had times when the PM 2.5 levels were over 150, and that was certainly evident by the visible smoke around us. And when we had teams scattered around different parts of Canberra, really only a few kilometres from each other, people with, we were in communication by telephone, etc., and we were recording quite different values short distances apart, simply because of the difference in the local environments, the direction of the wind, etc. So we found them quite useful, and I think if you rely on the government monitoring websites, unless you're right where that monitoring device is, what you're getting there may not reflect what is happening on the ground where you are with your athletic cohort. So in summary, I would say that the monitoring government websites are very useful for letting the local public health authorities know what the average level of exposure is going to be across the population of the city or the region, and therefore what they can expect in terms of presentations to emergency departments, etc. But I don't find them particularly useful in informing whether a training session should go ahead at a particular location at a particular time. And that's where I found these devices to be very useful. I'm just going to finish off by going through a coding system that we adapted from our local environmental protection agency here in Australia, looking at colour coding the levels of PM 2.5s and our general recommendations for exercise based on those levels. So at our green level here, which is less than 25 micrograms per cubic metre, as I mentioned earlier in the talk, this is what we consider normal, safe to exercise, and you won't have too many people affected at this level. Once we get in the range of say 25 to 30 micrograms per cubic metre, you will have some people who are, particularly those who have had asthma in the past, who are particularly sensitive to bushfire smoke, who may experience some symptoms. What I would say, under 50 micrograms per cubic metre, we would I would say that the vast majority of young fit athletes will cope with that without too much difficulty, but you may have some individuals who are affected and who may wish to either shorten their training period or take their training session indoors as opposed to outdoors, and who may wish to not train outdoors in this environment, on consecutive days. But the vast majority of people at this level will be able to tolerate this without too much difficulty. Once we start to get into the next level, which between say 50 and 150 micrograms per cubic metre, we definitely start to see increased presentations to our sports medicine unit here. When we're in this range, we had presentations from some people who had no past history of respiratory disease. We certainly had a lot of our asthmatics coming in who were significantly affected. And sorry, I know you're probably very highly unlikely to be able to read this writing, but I really just wanted to show you the classification system and speak to it. But I'll give you a reference at the end for being able to access this this categorization. So at this level, we're definitely seeing a lot of people engaged in aerobic sports presenting with symptoms. Those who are engaged in more short-term and intermittent type exercise activities such as tennis, netball, beach volleyball, cricket, power activities such as sprint training or javelin throwing or jumps training, a lot of those individuals were still okay in these levels, but as I've mentioned, it comes down to individual susceptibility, but definitely the duration high aerobic sports really struggled in these sorts of conditions, whereas a lot of the sports that were short duration managed quite well. And then once we get up to over 150, we really think that most people should delay their exercise or move their exercise indoors. And yeah, because if you have people exercising at this level where it's over 150 micrograms per cubic meter, you certainly will have presentations of individuals who struggle in that environment. If you have a sort of say a professional sporting engagement that is likely to go ahead, or there's a lot of pressure for it to go ahead, levels of this sort should at the very least trigger a conversation between the medical staff that are covering the event and the organisers of the event to see if there can at least be some modifications put in place where medical staff might have increased access to the field of play, if or there may be breaks instituted, etc., or some contingency in place should people be struggling in those conditions. But generally speaking, we would advise, if possible, that sporting events be delayed or postponed or cancelled when you get into this sort of level of PM 2.5s. Another point that I'll just finish with, and I know we're having this discussion here at the AIS, on account of the bushfires and what we saw and the effects that it had on our athletic populations here in Australia, because we had teams shifting around between cities trying to escape the bushfire smoke, only to have the bushfires spring up around them in the new city and still be affected wherever they travelled to. So it was quite chaotic. And here at the AIS, it's a great facility, but our buildings are old and our indoor training facilities do not have HEPA filters, which are these hospital grade filters. But in light of the bushfires and really the subsequent pandemic, what I would like as Chief Medical Officer here at the AIS is that our indoor training facilities all have HEPA filters, so that when these events happen, and I'm reliably informed that we're likely to see more frequent bushfire events, we're likely to see more frequent pandemics, believe it or not, going forward than what we've seen in the past. And when those things occur, I would like to think that we can offer people facilities that have HEPA filters, so that it's actually an oasis, a place of safety for people to come and train when these events occur. So certainly I've said to my bosses here at the AIS, for any future planning of new infrastructure, all indoor training facilities should have HEPA filters, and that's what we're intending to do. So the take-home messages from me are that bushfire smoke can have negative health and performance effect on athletes. There'll be a high degree of variability of susceptibility to the negative effects of bushfire smoke amongst your athletes. Even those athletes who have no past medical history of respiratory illness can be affected by bushfire smoke. PM 2.5s are useful indicators of the severity of bushfire smoke and the inherent level of risk. And athletes are more at an elevated risk of adverse events from bushfire smoke because of their increased exposure to particulate matter from prolonged higher intensity physical activity. And the AIS, the Australasian College of Sport and Exercise Physicians and Sports Medicine Australia, recommend using handheld devices to monitor PM 2.5 levels. And again, don't forget that point about any new infrastructure. You should consider installing HEPA filters if possible. And this article was published in the Journal of Science and Sports, Science and Medicine in Sport earlier this year. And most of the information I've spoken to is covered in there. So thank you very much for your attention. Thanks again for having me involved in this webinar, and I look forward to participating in the Q&A. Thank you.
Well, thank you, David. Another fantastic talk and a lovely overview of some of the challenges faced by athletes in a bushfire environment, which I'm sure will become more frequent, sadly, as the environment changes. Now, most people will, certainly in the UK, will have heard about bushfires as a major challenge around the context of the Australian Open and the tennis tournament. And there was a lot written about whether the tournament should go ahead, for instance. I know you've got a sort of first-hand experience of that, so perhaps you could share your thoughts about the balance between cancelling an event or trying to understand how you can mitigate or reduce risk for athletes partaking in sports like this? You're on mute, I think, Dave. Thanks.
James. Yeah, look, it's a good question. We, as I said at the start of this talk, this level of bushfire activity that we saw during 2019 and 2020 was unprecedented even for Australia, where we unfortunately have these fairly regularly. And particularly, say, around Canberra, I had not experienced in the last 10 years much in the way of sport disruption, but we certainly had major professional cricket matches in Canberra disrupted, where they had to stop mid-match. And interestingly, I mentioned during my talk that the type of activity undertaken by athletes has an effect on how much they're affected. So during that cricket match, those who are out in the field, standing in the field, who weren't bowling, were not affected. But certainly we had a couple of fast bowlers who actually broke down during their bowling spells because they found the bushfire smoke extremely irritating. And I was also working at the Australian Open tennis tournament when the bushfire smoke hit Melbourne. And it's interesting because they had shifted tennis tournaments around to try and avoid bushfire smoke, but it really did seem like the bushfires were following the athletes. They would move to an area where there was no bushfire activity somewhere out in the country, and then the bushfires would spring up around them. And at one stage, it was affecting really a large section of the eastern seaboard. But we certainly had to delay matches at the Australian Open. And I think the key difference between bushfire and the industrial pollution that Michael was talking about is that the bushfire smoke changes very rapidly, as I've mentioned, by just a change of wind direction. And varies a great deal across distances. So we had to delay some matches. All it took was a shift in wind, and suddenly the level of PM 2.5s would drop, and athletes would feel more comfortable. But during the Australian Open, we had highly trained athletes who, got into great difficulty with dyspnea during matches, and so we had some matches that were halted and had to be resumed later, and then we had sessions where we had to delay play.
In terms of the sort of symptoms that you saw in athletes, what sort of symptoms are the most prominent? I mean, from sort of personal experience of trying to help people with some of these exposures, they report sort of throat-focused symptoms or more upper airway type issues and irritation in that part of the airway, rather than the sort of asthmatic type symptoms you might expect. I don't know. I mean, you've got a huge amount of experience in this. Is that something you felt you encountered?
Yeah, it was interesting because it was quite different to, we obviously in an athletic population, we have a sizable cohort of asthmatics, and so we're used to seeing those individuals, and those individuals did present with bronchospasm type symptoms, so it certainly seemed to trigger their asthma. In those who had no history of bronchial hyperresponsiveness, who presented with symptoms, are often complaining of, I suppose you'd call it dyspnea and almost pulmonary pain. Like they were saying that they had a burning sensation deep in their lungs. We had several rowers present with this because, interestingly, the smoke would hang around on the lake. It would sort of tend to sink down and sit on the lake, and they were out there, rowing for 25 kilometres at high intensity and had huge exposure. And they would present with a burning dyspnea. But when we, as I've mentioned, we tested them for bronchospasm on spirometry, they had no evidence of bronchospasm, yet they were sitting in front of us having coughing fits and clearly in distress. So the only thing I can assume is that it was some sort of irritation from the nitric oxides causing a sort of interstitial or irritation. I'd be interested in Michael's thoughts on that if he's still online, but it was a presentation that we hadn't seen before, where people had clear respiratory distress, complaining of a burning sensation in their lungs, having coughing fits, but yet had no evidence objectively of bronchospasm.
Okay, great. Well, listen, thank you very much, David. Again, apologies, it's a rather short Q&A, but we do have some extra time at the end if there are questions, and people please feed them into the questions. And so let's move on now. Thank you again to David for a great talk. And I would like to introduce our final speaker of the evening, who's Dr. Guy Scadding, who joins us from the Royal Brompton Hospital, where he is the clinical lead for allergy. And Guy's going to give us an overview of how to tackle allergenic and seasonal issues that athletes face in their environments. Thank you very much, Guy.
Hi there, I'm Guy Scadding. I'm a consultant allergist at the Brompton Hospital, and I'm going to talk to you about allergen immunotherapy. And I'm going to try and tie that in with athletes. I have to admit, I don't know much about athletes, but I do know a bit about allergen immunotherapy. So I'll see if I can put the two together a little bit for you. So what is allergen immunotherapy? It's repeated administration of allergen extracts or products that could be altered allergen extracts to IgE sensitized allergic individuals to try to induce clinical and immunological tolerance on allergen re-exposure. That's a bit of a mouthful, but essentially it means you are giving the person the thing they are allergic to in an attempt to make them less allergic on future exposure. Generally, we do that in two ways. We do that with subcutaneous injections, which has been a very, very long-standing form of treatment, and also more recently with sublingual drops or tablets, but sublingual tablets being the more common. There are other modalities of treatment called desensitization, drug desensitization being one of them. That's not something we're going to talk about today. That's generally a temporary thing and doesn't induce long-lasting immunological tolerance. Food desensitization is something that may induce longer-term tolerance, but is the subject of further research. And then environmental desensitization or controlled exposure, that probably works by non-immunological mechanisms. And again, that's not something we're talking about today. So what are the indications for classic allergen immunotherapy? The principal indication is allergic rhinitis or allergic rhinoconjunctivitis. Other indications include allergic asthma with allergic rhinitis, so the two together. And then we also use it for systemic reactions to bee and wasp venoms, but that's less relevant here. It's effective in IgE-mediated disease where there is a relatively limited spectrum of allergies. It's not a treatment we use for someone who is allergic to multiple different things, but if someone has one or two easily identifiable allergic problems, then it's something that can be used. It needs to be combined with allergen avoidance and with pharmacotherapy and patient education. Contraindications to allergen immunotherapy, the principal contraindication is uncontrolled asthma. So anyone with an FEV1 less than 70% predicted or with a history of recent frequent exacerbations or high corticosteroid use would be contraindicated. The reason for that is because it's a safety issue. We wouldn't treat patients on beta blockers because they respond less well to rescue adrenaline. We wouldn't treat patients with unstable cardiac or pulmonary disease, active malignancy, active systemic inflammatory autoimmune disease, patients who are pregnant at the start of treatment, though if you become pregnant while on treatment, you can continue treatment, and we wouldn't treat patients who are acutely unwell for any other reason. What can we give allergen immunotherapy for? So in particular, this means which allergens. So efficacy has been demonstrated in large trials for grass pollen, tree pollen, house dust mite, cat dander, and ragweed. Ragweed is something not particularly relevant to us, but is prevalent in the northern United States. Also demonstrated efficacy for venom immunotherapy. You have to bear in mind that the treatment is only as effective as the vaccine you're given. So if the vaccine you're given does not have high concentrations of the major allergens, it's not going to be very effective. And there is discrepancy between major allergen content in commercially available vaccines made by different firms. If you're thinking about subcutaneous immunotherapy, a classic protocol involves dose escalation with weekly injections over about 3 months. Reaching a maximum maintenance dose, which can then be given every 4 to 6 weeks, typically for a period of 3 years. It can be done faster, so you can do cluster protocols or rush protocols, and there are modified allergen preparations given as depot injections, usually 4 times in the lead up to each season. They are not as effective and they haven't been proven to induce long-term tolerance. Sublingual immunotherapy, typically by tablets, involves tablets taken under the tongue every day for a period of 3 years. So allergen immunotherapy for allergic rhinitis or allergic rhinoconjunctivitis, the necessary things that we would have to have before starting that, we would have to have typical symptoms on exposure to allergen with confirmation of sensitization. That would be by skin prick test or by serum IgE test. Symptoms have to be troublesome. We wouldn't treat mild symptoms. there has to have been an inadequate response to pharmacotherapy. Typically, that's now a combined intranasal steroid and intranasal antihistamine. The most common of those is Dymista. There has to be an attempt at allergen avoidance, or allergen avoidance simply isn't possible. That's typically the case for seasonal allergens, for pollens. You can't simply completely avoid them. Even if you spend your whole time indoors, you're going to be exposed to some extent. But this is relevant when thinking about things like animal danders. We don't tend to desensitize people to animals, one, because at the moment we have no good available vaccines, but also because by and large, you don't have to own an animal. The exception to this is probably vets. There has to be an allergen product available in order to treat people. So there's no currently available good vaccine for cat, for dog, for horse, for molds, certainly not in the UK. So none of these things are viable treatment options. The patient needs to be able to comply with treatment. It's a lengthy treatment process. And unless you're going to have the treatment on a regular basis, it's not going to work. Absence of contraindications. Patients can be polysensitized. That means they can have multiple positive tests. But if they're multiply allergic, i.e. they're positive tests and there are multiple things that are clearly setting off their symptoms, they're going to do less well. This is the algorithm for treatment of allergic rhinitis from the BSACI. That's the British Society of Allergy and Clinical Immunology. I won't go through the whole thing, but you can see right at the bottom there's a slide that says consider immunotherapy. So really, we like patients to have tried everything first before going on to immunotherapy. Multiple reasons for this. One, most people will respond to pharmacotherapy, so topical nasal steroids, topical nasal antihistamines. Two, there are very few places in the UK that administer immunotherapy, so we're really swamped. And three, the treatment is not without risk and it's quite costly, so everything else needs to be tried first. Allergic rhinitis is extremely common. We're probably looking at a prevalence of about 1 in 4 to 1 in 5 people in much of Europe. So the question arises as to whether allergic rhinitis is more common in athletes. I think the evidence for allergic rhinitis being more common isn't there. Athletes probably have the same background levels as other people of similar ages in the general population, but obviously that's still quite high, up to about a quarter of people. Some disciplines have higher rates of rhinitis, but probably most of that is made up by excess non-allergic rhinitis. The best example of that is swimming, where exposure to the pool, to chlorine, seems to exacerbate nasal symptoms. Other endurance or distance events like running may also be associated with higher rates of rhinitis, but there's no evidence that it's allergic. I'm aware, having seen some athletes, that there can be a reluctance to use certain medications. Some of that is because of a question of whether or not medications are allowed in competitive disciplines. But most of the standard medications for rhinitis, so intranasal steroids, intranasal antihistamines, oral antihistamines, should all be allowed. It's also relevant that many sports events, the season peaks at exactly the right time for seasonal allergy exposure. So this is clearly an issue. So let's talk a little bit about immunotherapy for seasonal allergens. That's for allergic rhinitis with or without seasonal asthma. So this is evidence from a few different studies of grass pollen immunotherapy. The two in the left, where it's colored in yellow, are sublingual treatments. The one on the right is a subcutaneous treatment. And you can see that the effect size is pretty similar. And the effect size is all about a 40% reduction in medication use, a 30 to 40% reduction in symptoms compared to placebo. What's important to know is that in the placebo groups in these sort of studies, there's probably a 30 to 40% improvement anyway from baseline. So you're probably looking at patients on treatment getting 70+% better. So it's quite a big increase, but there's always a big placebo effect in such studies. One of the important facets of immunotherapy is illustrated here. So this is a study where patients are treated for 3 years with grass pollen immunotherapy tablets, and you see the data compared to placebo. And then they're followed up for a further 2 years once they've stopped treatment. And you can see that the improvement against placebo is still maintained. So it does have the effect of causing symptom and immunological tolerance. This doesn't go on forever. The evidence is there for it lasting up to 3 years after injection immunotherapy, up to 2 years after sublingual immunotherapy. In open observational studies, it probably goes on having an effect for 4 or 5 or more years, but those aren't fully controlled, so we wouldn't give any promises. We do need to treat some patients twice, so patients will be treated, come back after 4 or 5, 6 years, we'll treat them again. For perennial allergens, so year-round allergens, so most of the data for this is for house dust mite. That's the major perennial allergen throughout most of the world, certainly in Northern Europe. This is a study looking at house dust mite sublingual treatment, so tablets, using an allergen exposure chamber. This is a chamber, essentially it's almost like a big blow-up tent, where they put people inside the chamber and then they pump in house dust mite at a set concentration, and they record how people get on it over the next 4 or 5 hours in the chamber. And they use this to compare the effect of different concentrations of the tablet treatment against placebo treatment. This is what one of these chambers looks like. So pretty complex business. So the data from the chamber studies is excellent. So these are patients who have challenges at set time points during the treatment phase, and you can see after just 8 weeks of treatment, patients on tablets are getting a 20% improvement versus placebo. And if you extend that up to 24 weeks, these patients are getting a 40-50% improvement versus placebo. So in these sorts of highly controlled situations, the treatment is extremely effective. What is somewhat more disappointing is that when you take these studies and then you do them in real life, so not in controlled allergen chambers, but in day-to-day life, a bit like the studies I've shown you for grass pollen, the effect size is significantly less. So in these 2 studies using 2 different preparations of dust mite sublingual treatment, you can see the effect versus placebo is only about 20%. It's still highly significant, but it's not as promising as 40% plus. Again, what you have to note is that if you look at the scores over time, you'll see that the placebo group get 30-40% better. So again, your patients are going to be about 50-60% better than baseline, but there's a huge placebo effect in these studies. So the effect size doesn't look quite so good. So for sublingual treatment for house dust mite-induced perennial rhinitis, the treatment is effective, but there's a very high placebo effect. The effect size, so somewhere between 17 and 20% versus placebo, is less good than for the pollen treatments, where you're looking at 30, 35, even 40% versus placebo. The reason for this is it's unclear why this is. There's probably more heterogeneity in recruiting patients for perennial allergic rhinitis studies. It's harder to say that the dust mite is the sole trigger for their symptoms. Whereas in patients who just have seasonal symptoms with pollen exposure, it's very easy to pick the patients who only have that as their major trigger, and easier to run the studies. What about house dust mite immunotherapy for allergic asthma? There's been some good studies in recent years for this. This is the tablets, sublingual tablets for house dust mite immunotherapy. In this study, they took patients, they gave them 3 different concentrations of the tablets versus placebo. They had patients with asthma on inhaled corticosteroids, and what they aimed to do is to see if being on the treatment could allow the corticosteroid dose to be reduced and the patient still to have adequate asthma control. And what they found was, in this proof of concept study, that for patients on active treatment versus placebo, you could overall get a 42% reduction in inhaled corticosteroid dose versus a 15% reduction. And that equated to a reduced daily dose of inhaled corticosteroid of about 80 microgram. So significant, but probably not really that meaningful. On the other hand, if they did a subgroup and they took patients who at baseline were on slightly higher doses of inhaled corticosteroids, they found that daily reduction in inhaled corticosteroid use, with the patients still remaining stable, was much more significant, so greater than 300 microgram. So it shows that being on this treatment can enable you to reduce the amount of inhaled corticosteroid you need to maintain asthma control. This next study, rather than looking at the effect of how you could reduce inhaled corticosteroid dose, looked at what would happen if you simply took away the inhaled corticosteroids to patients on 2 different doses of treatment versus placebo. And what they did was they stabilized patients on inhaled corticosteroids at the start of treatment, treated them for 6 months, and then took away the corticosteroids in two phases. One, they halved it for 3 months, then they withdrew it completely. And the endpoint was to see how quickly patients exacerbate and whether being on the immunotherapy treatments could prevent or reduce exacerbation rate. And effectively, they found that being on treatment reduced your risk of exacerbating by a third. So it's clear water between placebo and being on active treatment. And a third doesn't sound that much, but actually it's not so different from the approach used for some of the biologics for asthma, and the change is not so different. So actually it's highly significant, and it does seem to protect against exacerbation, at least when inhaled corticosteroid dose is reduced. So these studies led to house dust mite immunotherapy sublingually being incorporated into the GINA guidelines at sort of steps 2 and 3. So mild to moderate asthma with house dust mite sensitization and allergic rhinitis, house dust mite immunotherapy is a potential adjunctive treatment. I mentioned that there are two approaches, sublingual or subcutaneous treatment. How would you choose between the two? Well, most of that is currently dictated by availability. But in an ideal world, if you could choose both, to some extent, it would come down to a patient choice and a decision about convenience. Undoubtedly, sublingual immunotherapy is safer than subcutaneous immunotherapy. Subcutaneous immunotherapy does have some risks of inducing a severe systemic reaction. We'll talk a bit about that in a second. In terms of the meta-analyses, both show a clear effect size compared to placebo in the studies, and there's not really anything to choose between them in those studies. In terms of safety, subcutaneous immunotherapy induces some form of systemic reaction in about 1 in 1,000 reactions. It'll be life-threatening in 1 in 1,000 injections, life-threatening in about 1 in 1,000,000 injections, and death in about 1 in 2 to 2.5 million injections. Now that's looking at the entirety of injection immunotherapy use, and I'd say that if it's done carefully in controlled settings, then that risk is I think very, very minimal. We've never had anything like that here, but it does mean that you have to be cautious about your approach. Sublingual immunotherapy, there have been no reported deaths. There are a handful of reported cases of anaphylaxis, but several of those have been associated with patients taking too many tablets all at once because they missed doses. The problem with sublingual immunotherapy is really local reactions. And this is just an illustration of those local reactions. This is with data from the tree pollen tablets, which again are highly effective, but you can see patients on active treatment get significant problems with itching in the mouth, irritation in the throat, numbness, swelling, lip swelling, ear swelling, sometimes with oropharyngeal pain as well. So these symptoms are very, very common. And in the studies, about 8% of patients discontinue because of these side effects. I'd say in our clinical experience, it's probably more like 10% of patients just say, I can't tolerate this, or we just can't get them to be able to take the tablets regularly because of these side effects. So subcutaneous immunotherapy has those risks of severe side effects, which sublingual immunotherapy doesn't. On the other hand, there's probably a 10% dropout rate because of sublingual immunotherapy causing local irritation. Adherence is a major issue. If you look at the studies out there that monitor how many patients who begin immunotherapy complete 3 years of immunotherapy, then there are levels as low as 18%. Some studies suggest much higher, but it's really very variable. And it's also worth bearing in mind that in clinical trials, more people will take higher doses throughout the trial than they do in real life. So it's really important to pick patients who are committed and who will stay the course for the whole length of treatment, because that's when they'll get the best benefit. So the main causes for people not adhering to treatment are the side effects, which you talked about, the inconvenience of treatment. That's particularly true for the injections, because you have to attend the clinic, lack of efficacy, or just patients simply forgetting to use the treatment. How would we predict who would respond to treatment best? And the answer, we don't really have biomarkers yet. There's a study out there for house dust mite treatment that suggests that serum periostin may predict a good response to treatment, which is interesting because it's similar to patients responding to some of the biologics for asthma. So obviously seems to be a marker for allergic responses. But at the moment, that's not something that we would generally use clinically. So the biomarkers we have are a clinical history, so a careful clinical history, examination, and that's principally to exclude other causes. So does the patient have structural causes, nasal polyps, anything else that might be causing their symptoms? And then does the patient have clearly positive skin tests or specific IgE to the relevant allergen? We now have access to allergen components, so we can test to see whether patients are sensitized to major allergens within pollens, within foods and other things, rather than a minor allergen. I have to say, that's not actually yet proven to be very useful for allergic rhinitis, because the vast majority of patients we see are all sensitized to the major allergen. There are investigational tools out there like basophil activation in vitro or nasal provocation tests. They may have a role, but not in general clinical practice as yet. So in summary, immunotherapy is an effective treatment for common causes of allergic rhinitis and allergic rhinitis with asthma. It's an adjunct treatment for house dust mite induced allergic asthma at present, so something you'd use in addition to standard treatments. We reserve it for patients failing to respond to standard therapy. There's a low risk of severe systemic reactions with sublingual treatment. The risk with subcutaneous treatment, I don't want to overemphasize it, it's still very low, but it is there. But with sublingual treatment, there's quite a high withdrawal rate due to local side effects. And with both treatments, there's poor long-term compliance. So patients need to be well motivated and understand they need to take this treatment long-term. The biggest barrier to treatment is probably the fact that in the UK, at least, there are really very few centres providing this treatment. Our current wait list for grass pollen immunotherapy is 3 years, slightly less for dust mite and tree pollen immunotherapy. So we just do not have the capacity to treat more people. Plus, funding is an issue. There's no nice pathway or guideline for recuperation of funds. So our hospital has to provide the funds for the patients we treat. All right, I hope that's of interest and of use. Thanks very much.
Massive thank you, Guy. Great talk indeed. And I think hopefully provide people with all the information they need with respect to how to approach and think about that top end of allergy treatment, really, which is sort of down at the bottom end of a treatment algorithm. Lots of people will be asking, look, I mean, here we go. We're in middle of May. Certainly in the UK, pollen numbers are going up. We just sort of wind back one step, and what would you expect people to be talking to athletes about as what is standard or good practice in terms of trying to get on top of allergies before they might consider a referral for immunotherapy?
Yeah, James, good question. The need to begin treatment early and the mainstay of treatment for anyone with more than just very mild symptoms would be an intranasal corticosteroid. And if you're using that correctly and you're using that on a daily basis, that should achieve control in the majority of people. You can add on an oral antihistamine to that if you like, but the intranasal corticosteroid is more effective. So that would be the first line treatment that anyone should be on. If they're not doing well enough with that, the next step would be to move them up to a combined intranasal steroid and intranasal antihistamine. We use Dimista because that's until very recently been the only one available. There is one called Realtris as well, which is a different combination. But so those two would be the next line. And I'd always emphasize, are they using it in nasal inhaler correctly, and are they using it every day? Because I think so many of the people we see don't take it on a regular basis. I'll speak to them and they'll say, "Oh, I use it when it gets bad," and I say, "Well, that's no good. If you use it every single day, it won't get bad." So that's the important thing.
Okay, and okay, let's say that an athlete is referred or is considered for immunotherapy. I know, for instance, in Europe, it's much more widely accessible or more easy to access, and certainly a number of athletes that I would see from Europe are already on immunotherapy, and often they've had different trials with different forms of immunotherapy. For those who aren't fulfilling an NHS or completing an NHS pathway, do you have a rough idea of the sort of cost of these types of drugs, or how much they cost to actually set up and run?
Yeah, roughly speaking, in terms of the sublingual treatments that we use for 3 years of treatment, the drug cost is about £3,000. So you'd have to then that's the drug cost. You'd have to then add whatever amount you would be paying for visiting a doctor to have that done. In terms of subcutaneous treatment, there are some cheaper vaccines out there, but then you would have the added cost of going to see the practitioner to have the injections done.
Okay.
You're looking at that sort of amount.
And then just winding back a little bit further, question about the difference between skin prick tests and blood tests for allergy, and advantages and disadvantages of those. I suppose from a practical point of view, you know, some are more accessible than others, and is there an advantage of skin tests over blood tests in that context?
The short answer is not really. For common aeroallergens, for the sort of things we're interested in, tree pollens, grass pollens, animal danders, house dust molds, they're equivalent. So don't worry if you're not able to do a skin test, send serum IgE tests to the relevant allergens, just as good.
And I suppose as the advantage, you don't need to be off antihistamines if you have a blood test done, but you do if you do have a skin test. Is that correct?
Yes, exactly. So the blood test can be done at any time.
And in terms of antihistamine tablets, a question about what sort of tablets and dosing would you recommend? Are there ones that are favoured in athletic populations?
I don't have any particular data for athletic populations. I would say that the antihistamines that I find most effective would be cetirizine and fexofenadine.
And I know you sometimes use slightly higher doses than
we use
might, but...
we use higher doses for chronic spontaneous urticaria, because there is evidence that higher doses, in fact up to 4 times daily dosing, it will gain control in some people, whereas lower doses won't. The evidence for allergic rhinitis isn't there, so there's not really any evidence that using any more than a single daily dose is helpful. I will, for people really struggling, I will sometimes say, fine, take it twice a day, and that's mainly because we know it's safe, not because we know it's any more effective.
Okay. Well, listen, thank you, Guy. A lovely talk. And I know people can contact you if they have questions or people they'd like to refer. So big thank you again.
Sure.
And so it leaves me really to bring this evening's overall symposium to a close. I'll just very quickly check if there's any further questions that have popped up into the online Q&A. Which they haven't at the moment. So yes, well, listen, first of all, a massive thank you to our 3 fantastic speakers, Michael Koehle, David Hughes, and Guy Scadding, who I hope have provided you with a overall insight, or certainly some new thoughts about the way in which we can help athletes who have to, in many cases, exercise in somewhat inhospitable environments at times. Big thanks to the organising committee, to Kelly from HCA for helping us organise this, and to the host for this evening. I know that there were a few glitches at the very start of the meeting, but the full meeting will be downloaded and video files will be available to you. So hopefully, if you've missed anything, you can watch that back at your own leisure. Hopefully, the speakers have put their contact details in. So if there are any further questions, forward them directly to the speakers or via ourselves and our team and Kelly, and we can try and help you and address any specific questions. Final plug, of course, to the ISEH websites. You can sign up to the newsletter. There's an ISEH feed on Instagram and on Twitter, and there are a number of other courses coming. Of course, tomorrow night, Sabiha Gati will be chairing the cardio component of the cardiopulmonary symposium. And there is also, as I said in my introductory talk, a hands-on, face-to-face workshop looking at helping athletes with their breathing performance in June, of which the details are, again, on the ISEH website. Big thank you, and I will say good night to you all, and thank you again for joining us.